If you ask me about the intraoperative challenges, patient with prominent incisor teeth and patient with a mobile teeth, in these type of patient, while inserting a laryngoscope, there is always chance of the teeth extraction. So patient can develop airway edema and ultimately breathing difficulty.
Hi, I'm your host, Dr. Smarika Bhatt, and today we are going to discuss about an important topic that rotates around transoral laser surgery in early laryngeal cancer. To join us with this conversation, we have Dr. Bhavin Vadodariya, a board-certified consultant surgical oncologist with impressive credentials including an MS in general surgery and DRB in surgical oncology. He currently leads the head and neck surgery department at SSO Cancer Center, Epic Hospital in Ahmedabad. Come to the podcast, Dr. Bhavin. We are excited to have you here.
Thanks, Parika. Likewise, and thank you for kind introduction.
Without further ado, we'll jump right into the first question. So we'll talk about transoral laser surgery or TLS for early laryngeal cancer. Many physicians want to know that what kind of patient should we be considering for this approach and what clinical factors help you identify the ideal candidate for it.
Okay, so first let me tell you what TLM is. TLM is a transoral laser microlaryngeal surgery. So let us divide it in parts. So it is transoral. So it is surgery being done through the oral route, and laser means it is surgery done by a laser using laser, and microlaryngeal, that means a part of larynx which is highlighted into microscopic view, which is very tiny, which I mean by a vocal cord. So indication for this surgery is, I would suggest, early laryngeal cancer, especially vocal cord cancer, which is known as a glottic cancer. So whenever there is a T1 and selected T2 glottic cancer, these lesions are treated by transoral laser microlaryngeal surgery. So now onwards, I will tell the surgery as a TLM or TLS. So this area is in the neck. It is inaccessible through the oral route, but by means of proper instrumentation in form of laryngoscope, suspension laryngoscope, along with a microscope and micromanipulator and use of laser, this surgery is done precisely. Because vocal cords are very tiny structures, I would say hardly it is of 1 or 2 centimeter, and lesion for them may be of a 5 millimeter. So in this surgery, 1 mm, even very good precision is required to reduce the surrounding tissue damage. So if you ask me about the which patient to go for a TLN, these are the T1 and T2 early glottic cancer.
Okay, Dr. Bhavin. So as you have touched upon the radiotherapy in the previous answer, so let's move on to the next question, which covers like how does TLS compare with radiotherapy in outcomes like voice preservation and quality of life different?
So TLM and radiotherapy both offers better oncological control and nearly same voice control. So if you talk about the percentage, you referencing the latest meta-analysis and the randomized control trial, I would say all studies have mentioned that TLM and radiotherapy has nearly same oncological control in form of a local control. That means a recurrence-free survival or disease-free survival and overall survival. So overall survival, recurrence-free survival, and all are same, nearly 90 to 95%, and in some cases 97% also. But as far as the voice outcome is concerned, initially TLM patient may have a breathy voice or quality may not be that good, but after the 6 month quality of the radiotherapy as well as TLM is nearly similar voice outcome. So if you ask me about the differentiating factor between those two modality, is I already mentioned you. I would say in the Indian setup, TLM is cost effective because it is done in single setting. Patient can be discharged in the same day or next day. So most of the centers offering this surgery between, I would say, 70,000 to 1.5 lakh. in a single setting. But if you compare it with radiotherapy, it can range up to 1.2 to 2 lakhs for the same, and patient has to travel every day. You can repeat TLN if patient got recurrences. So if I tell you that I have operated T1 glotic cancer with a TLM and same patient is can develop recurrence, re-TLM can be done. But doing re-TLM in a patient who has undergone radiotherapy are associated with so many issues, such as snake fibrosis. These are the radiation-related side effects, which may ultimately lead to the, first of all, limited access to the vocal cord. By forming a neck fibrosis, you cannot achieve a good extension. Another thing, tissues are very fibrous. So it is very cumbersome to do laser in this type of a patient. So that is one advantage of a TNM. But I would say the patient who have access difficulties, such as patient who doesn't have a mouth organ, such as trismus, patient who cannot extend their neck because in this surgery extension is required, such as cervical spine disease. In this type of a patient, I will prefer radiation over the TLS. One more point I am favoring radiation is a lesions near anterior commissure. Anterior commissure is an area in which both of vocal cords are touching each other. So that is a V-shape area. So why AC is more important, anterior commissure? Because that area is directly connected to thyroid cartilage. There is no inner perichondrium there. So disease can rapidly spread to the bone. And if I do laser in this type of a cases, in a long time healing, there will be a web formation, which can ultimately reduce the quality of voice due to more of granulation tissue. So in that case, I'll prefer a radiotherapy. And in the patient with a bilateral vocal cord lesion, so if I do TLM in both vocal cord, I think quality of voice will be very bad. So in this type of cases, I will prefer radiotherapy. So crux of my assessment of these two technique is, so whenever you have access issues for the TNM, go for radiotherapy. Pathology wise, anterior commissure lesion, go for radiotherapy. Otherwise, TLM is better.
Okay, that was really insightful,
And
Dr. Bhavin.
yeah, and both have similar oncological and voice control. If you ask me about the oncology and voice, both have similar results.
Okay, so that was perfectly explained. So let's move on to the next question is, so what challenges do patients typically face after surgery? Like how do you manage them?
Okay, so post-operatively, TLM patient, I will see if they develop a laryngeal edema because there is so much instrumentation is being done in this small area. So patient can develop a airway edema and ultimately breathing difficulty. So I usually prescribe the steroid for 3 days or maybe a week to reduce edema. Then patient will have, as patient's vocal cord, part of vocal cord has been removed, there is chance of aspiration while swallowing or while swallowing saliva or by taking food. So I usually tell them to go for a thick liquid diet so they cannot aspirate the food into lungs for a week. And I ask patient to do adequate voice rest to increase the healing and give the vocal cord rest for 7 days. So post-op challenges are aspiration as well as airway edema. And if you ask me about the intraoperative challenges, patient with prominent incisor teeth and patient with a mobile teeth, in this type of patient, while inserting a laryngoscope, there is always chance of the teeth extraction. So that to decrease the incidence of a same, I always apply the mouth guard before starting this procedure to protect the teeth. So these are the challenges. And if you ask me about the long-term complication, so if we can't use laser precisely, there will be more charring of the tissue because of the excessive laser use, which can ultimately reduces the quality of voice. For the same, TLM was preferred. So we should be very judiciously use the laser to cut the tissue because your laser precision will determine the quality of voice patient have. And always always consider, means thinking twice before you are considering a laser in an anterior commissure laser or near anterior commissure laser, where granuloma can be formed, wave can be formed, and ultimately reduces the quality of voice. Yeah.
Thank you, Dr. Bhavan, for addressing the post-op challenges. This clearly requires specialized expertise. So let's move on to the next question is, how steep is the learning curve for surgeons interested in offering TLS? And how accessible is this technology across different healthcare settings?
Yeah. So let me get through the straight message to the upcoming residents and the upcoming surgeons who want to perform TLM. So I would say, to do a TLM, you should have a great attitude to not let you fall down for a patient. That means, apart from a surgical skill, you should have a better mindset to do better. How? Because setup for the TLM is the best method to develop a successful TLM for the patient. Why? Because if you cannot access the vocal cord properly in a microscopic view, then your precision for the laser will be gone. So, learning curve is moderate, and you have to apply instrument perfectly according to patient's anatomy. You have to apply the video endoscope. You have to apply the microscope and focal length of microscope, diameter of the microscope, ear eyepiece and all. This should be checked, and laser setting should be pulsed or continuous. The laser beam, which should be vertical, horizontal, or crescent shape, and laser length, laser force, this all should be keeping in mind before you contemplate a case of TLM. So if you do setup very good, you can see your lasers clearly in 360-degree view, then you can do better. So this is how the learning curve is. Yeah.
Okay, thank you so much, Dr. Bhavin, for addressing such important topic, and I'm sure our audience will get a valuable insight from this conversation. And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions and contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care.